Well, good afternoon, everyone, and welcome to our imaging conference at the beginning of the year. And whoever is reviewing this over YouTube or other channels, I'd like to go through some of the basics of imaging. And today will be the basics of ultrasound. I think echo is known to pretty much everyone. And what I'd like to do today is basically go through some of the basics of ultrasound. Let's see if this is, there you go. It's helping us out here. And this technology has really evolved so much over the years that I know we take this for granted, but you as an imager, somebody who's interested in imaging, my advice for you is always try to understand the basics of how these images are obtained so you know exactly what are the advantages, some of the limitations, technical limitations, so that you can behave as an expert, right? It's always good because you would be fooled at times in some artifacts or some issues that you may get that you may not be familiar with. But I think for you to optimize the technique to answer the particular pathologic, physiologic, structural question, you really need to know what goes on behind the scene and behind, this technology that has evolved. So now we have a family of techniques, 2D, Doppler, color Doppler, 3D, contrast, and so many other things. So let's go through the basics. Ultrasound, just like the word says, it is beyond your audio range, and therefore, from a wavelength point of view, it is very short. The frequency of the ultrasound is usually above 30,000. So that you're not going to be able to hear it. And the audio range is below that, and I think if you still have good tympanic membranes and a good connection of your tympanic membrane to the brain, you can hear audios at very high frequency, which will be very screeching, to very low frequency where it is on the lower end. So wavelength, by definition, is what you see there is that's the wavelength of it. And the frequency is basically the numbers of these cycles per second. That's in hertz. The speed of ultrasound in biological tissue is about 1.5 kilometers, so 1,540 meters per second. And I think that's important because that's how you determine ultimately what's the depth of a certain structure, right? Be it here or whatever it is, that's how you're going to be able to determine it. And last but not least is just like any other waves and other things, the properties are once you emit a sound or you send light or whatever it is, that sound can propagate depending on the milieu, can slow down. The best propagation is probably in a fluid. The lowest is in air or even no air. And some of it will be reflected, some will be refracted. These are terminologies that you may want to know, and it's similar to light. So let's go through some examples here. So you have this ultrasound transducer, and the transducer, we're not going to go into it, but I think it's important for you. It has a lot of crystals, piezoelectric crystals, meaning if you excite them, either mechanically or electronically nowadays, they emit a little burst of waves, and that's what you want to do. You want to emit a certain burst of waves that goes and reflects a surface, and that surface for us obviously would be part of the heart, could be a muscle, could be a valve, could be whatever it is. Now it reflects it and refracts it first, so if it continues, if it has enough energy, it's going to go through, and it depends on the properties of that surface, will be refracted and goes down further, so it loses some of the energy. Some of it is reflected, so if you're at an angle, it is, if you recall your physics, it will be reflected there, and notice that this line is getting thinner, right? And interesting enough, for us to be able to record from the same transducer, you have to have this little tiny, tiny, tiny fraction that comes back straight to you, right? So just imagine how much of that energy, of these waves that are sent in the body, how much of it is reflected straight to you. So number one is you get back to the transducer a very tiny fraction of what you emit. That's number one. If you want to get a maximum of that emission, you have to be perpendicular to the structure, and we know the structures are not linear, right? So you have to be perpendicular to the structure, so that little arrow of white that is going back out is actually merging with your red arrow coming back to the transducer. Okay? So I'm going to talk a little bit about how this works. So if I send sound all the time, like this, right? If you send it all the time, and it's reflecting from the walls, from the various structures, you have no idea where it's coming from, number one, and how deep things are. So in ultrasound, part of the principle is you send a packet, all right? 3 or 4 or 5 wavelengths of these that are going in a packet. So you can track them, they go somewhere, and they get reflected, and then you can analyze them, right? You can analyze them for intensity, you can analyze them for frequency shift. So you have to send packets, because if you grew up in the mountains or in a valley, that's the same principle. You have a little shout, and then it goes out, and then it comes back, and actually if you're smart enough, you can tell how far this this valley is. Same thing, there's another application. If you see lightning, right, and then you hear the thunder afterwards, you can actually tell how far this cloud is, because the speed of light is very different than the speed of sound, right? So we send these packets, okay, and they go and get refracted, reflected, and for the best for us to see is you have to be perpendicular to that structure. An example for you is what? Is an atrial septal defect. Okay, an atrial septal defect, for you to be able to see it, it is such a thin structure. Parasternal window is not your way to do it. A 4-chamber window is not the way to do it. For you to be able to see it, it's going to be either a subcostal, perpendicular to the atrial septum, or a low parasternal, a little more perpendicular to it. So these are some of the clinical applications, okay? So how about these various letters, right? You hear about an A mode that you've never seen probably in your life nowadays. It is A is for amplitude. So let's take an example of this red and blue structure, whatever that structure is, a dot, a pin, if you will, right? So if I send this burst of packet to it, on an A mode is an amplitude mode. And you don't see them anymore. You can, for historical purposes, you could take a look at that. So the first one, which is less reflectant than compares to the second one, which let's say could be calcium, more reflectant, your wave is much larger. Now you can take a look at me. If I take this vector and bring it down to you, you're going to look at brightness as opposed to amplitude. So B, or B mode, is for brightness, and that's what you see nowadays on a 2D echocardiogram. These dots of ultrasound are actually the brightness. It's a B color at times, if you colorize it, if you will. So if you take that vector and look at you, then I know what the intensity of that reflectant is. So I maybe differentiate the blood, which doesn't have much, to muscle, to calcification, to metallic thing that is very reflectant, right? So that's a B mode. And then M mode is motion mode. Okay, it's not the letter M, it's motion. It's not the mitral valve structure, the way it moves, and it's motion. So why would I want to do that? Because at times I'm interested of how these reflectant waves are doing over time, because the heart is not a static structure. So if I take this B mode, this dot, and have a strip of time on it, if it is not moving, it stays as a line, right? And if it is, let's say, a mitral valve, it's going to go up and then down, and then you're going to start seeing various things that you've gotten familiar to. And this is where, it's great for M mode because it has great time resolution, right? And we'll talk about resolutions down the line. So an example of M mode of the aortic valve on top, right? It opens up, it almost looks like a box, and then it closes, mitral valve motion, and then you can take a look at the anterior wall of the right ventricle, then the right ventricular part of the septum, the left ventricular part of the septum. So these are the structures. And M mode has great characteristics, actually, and we always talk about it in the lab, how they differentiate all these septal motions that are quote-unquote paradoxical. There are 7 of them. And if you're really good, you should be able to draw them, okay? Draw how the septum moves in each one of the paradoxical post-surgery, volume overload, pressure overload, a constriction, etc., etc. And I would push you to do this. As cardiologists, you should be able to actually take a QRS, PQRST, right? A cardiac cycle, and write under it what the pressures are in various chambers of the heart, what's the motion of the valves, when do they open, when do they close, how do they look like. This is how you're going to learn physiology. Not only by osmosis, but actually doing the work, all right? Because actually the more you understand it, the better you can teach it and the better you can own it, okay? So enough about M mode and how do we make. So well, how about 2D, right? I mean, you have the beautiful structure here, a 2D echocardiogram. How is that done? Well, if you understand the principle then of an M mode, right? If you understand the principle of reflection, so this is here what the intensity of the reflection of the wave. Well, 2D is done based on basically scanning, you know, each one of these lines of ultrasound in the field of view. Why is cardiac ultrasound in a V shape or 90 sector or 30 sector? Because you have to deal with ribs, okay? If you're doing abdominal ultrasound, actually you have a box. If you're doing a vascular ultrasound, most likely it's a linear array, so you have linear, so you don't have to scan it, it's just like basically a linear array. But for us, I think you have to do that. And there are some issues with that because obviously you could see how tight these lines are close to the transducer and how wide they are down there, right? So that's important from a lateral resolution point of view. And also tells you that because I have to scan from time to time for me to be able to see this and as close to real time, there is a certain frame rate that you have to deal with. So it has lesser temporal domain than an M mode, for example. But over time, things have evolved significantly that you could do a parallel processing for these so that you can get nowadays for even a 90-degree sector, you can get frame rates on the 120s, 130s frames per second, which is very good, which is really close to real time. Contrast that with other technologies like CT, MRI, right? And this is where the importance of real-time imaging, which is very close to real-time imaging nowadays with 2D that you can get. Color Doppler is a little different ballgame, drops your frame rate. 3D drops your frame rate, so we have to talk about that. So you have to think about temporal resolution. How about spatial resolution, physics? You know, I mean, can I differentiate a dot from another? Okay? And take a look at the bottom of this. The higher the frequency, the tighter, the shorter this wavelength, the higher the frequency is, the more I can differentiate between two dots as opposed to having a larger frequency where I really cannot differentiate these two dots. So the higher the frequency, and nowadays you have the advantage of technology. When I grew up in the field, you had to change every time your transducer. Well, this is a 2.5 transducer, this is a 5 transducer, this is a 7. Now, you can dial in, how much frequency do you want because these are broadband transducers, right? So you can emphasize one or the other of the lower or higher frequency transducers. So for axial resolution, so in the line, axial resolution, okay, differentiating one from another on the top, on the axial resolution, along the line of the ultrasound beam, frequency is your main key. The higher the frequency, the better, okay? So you can differentiate and you get down to millimeter level, sub-millimeter level. Lateral resolution is a different ballgame, because if you have to think of these scan lines, they're not a line. They're basically a little tube that gets wider and wider the further you go away from the emission of where the tube is. So you could see that non-focused beam. There's focused beam, so you could almost have a electronic lens, if you will, that focuses the beam. So I could, and you'll see that at times as this one here, for example. See this arrow? That tells you where the focus is of that particular ultrasound. So you could change that, you could bring the focus up and down. We don't do it as much, but at times you may want to, but most of the time I think we've done well without changing much the focus. But irrespective though, that your lateral resolution of differentiating two dots close together in the lateral space as opposed to the axial space really will depend on the beam and focusing of the beam. So I think that's going to be very important for you. And overall, in general, lateral resolution is lower than axial resolution. That's why, again, you know, for you to be in the axial resolution, you'll be perpendicular to that, right? You have the best reflection of ultrasound in addition to your, you know, best resolution of it. Okay? So now we send these bursts, they come back, we analyze them for speed, and that's how your scale is. Your scale is because of, you know, what the speed of ultrasound is in the body, and you know how long it took for that little burst to come back and reflect on the screen. So I know I can have a scale, a depth scale, although it is not a true depth scale, right? Solving the equation, and the equation is fine throughout. Now, 1, 2, 3, 4, 5. Okay, and you've heard about these. Overall gain. You increase the gain, decrease the gain. Time gain compensation. You've seen all these, you know, buttons, scales that you could change. This is called time gain compensation, telling us about the time that it took, basically the depth gain compensation, right? So it's time gain compensation where I could decrease or increase the intensity of what's reflected back. I really haven't changed anything of what the transducer is emitting. It's all about what do I do post-processing. When this ultrasound comes back and gets processed, I could change the display of it. I could increase the gain, decrease the gain, put a reject at the bottom, compression, all this. And I put in blue the mechanical index, which is really the only one that you're changing, emitting, as opposed to receiving. Okay? So the emission is the mechanical index, that's the output power. And that power is very important because you think of ultrasound being benign. Right, it is benign because it's regulated. You know, the machines are not allowed to go beyond a certain output. If it does beyond a certain output, you can still have ultrasound that can break gallstones, that can fry certain tissues. So, I mean, you can emit as much energy as you want. And this is, I think, this is safety not only for the adult, but also for the fetus, because you use this also in fetal ultrasound. Okay? So the output power is important. And why do I bring it? I mean, you don't have to worry about it. In the past, we never worried about it. But I think you have to worry about it because of the application of contrast. And I know we're going to have a session on contrast. For those of you who are following us on YouTube, we have a full dedicated hour on it, so you can take a look at it. And what is this mechanical index? Okay, it is not your myocardial infarction, it's an MI. Peak negative pressure divided by the square root of the frequency that you send. Okay, and most of the frequency that we send is usually between 1.5 megahertz all the way to 7. I think that's most of the time. Times you could use frequencies even to the much higher range, 30, right? But not in cardiac ultrasound. It's at the tissue. It's almost having histology, basically, from that. So why is this important? Because if you use it for bubbles or other things, it is not the pressure with the positive pressure, it's the negative pressure, right? So you have a wave that goes up positive, negative. And if you're somewhere where you have a big boom box, that, you know, driving close to somebody who has a big boom box, you feel the positive pressure much more than the negative pressure. So just imagine on the negative pressure what happens to these. This is where the burst of ultrasound bubbles occur. Now, we're talking theoretical here because it is a fraction of a millisecond that this occurs. You can't really differentiate positive from negative, right? I mean, this is very short duration. Okay? So we'll keep that in mind. And what's a mechanical index that is high? Usually above 1. Lower than that, and with contrast ultrasound, you use 0.3, 0.2, basically on the lower end to try to keep the bubbles alive as much as possible so you can see in the myocardium and other things. These are very important things. You have to understand the principles of ultrasound, and they are also in your guidelines and the implications of such a thing. Principle of ultrasound, you can have reverberations, you can have attenuation, and I think these are very important. The reverberations, actually in this example of a prosthetic valve with a thrombus on top, there are examples of reverberation and attenuation, okay? Something very interesting happens with these prosthetic mechanical valves, okay? It is so thin, the ultrasound reverberates between the two and gives you a shadow as opposed to an attenuation. Okay, so you see all this shadowing here. Okay, that's an artifact from these little tiny, reflections of ultrasound within the mechanics of the ultrasound of the prosthetic valve itself. This is an example of attenuation, meaning I have a very highly reflected area, which is the annulus basically of this, or it could be a piece of calcium in somebody with calcification. Ultrasound comes here. Most of it gets reflected back up, and there is very little that goes down. Remember the reflection and refraction. If you don't have refraction, meaning going further down, you're not going to be able to reflect back again, right? So if I've reflected most everything here, there's no further ultrasound, or there is very tiny that I can't even see that doesn't get reflected anywhere else, right? So remember then, if I have a highly refractile surface, okay, all the ultrasound is going to come back. I can't penetrate further. Therefore, I can't image further. It'll be all black. And the same thing will apply to Doppler, because Doppler is solving an equation. So that's the same thing for Doppler in a mechanical prosthesis. Let's say in the mitral position, I can't see anything behind it, and therefore I can't interrogate with Doppler, and therefore I can't understand whether there is regurgitation, yes or no, okay? So attenuation is critical, all right? So I'll put it in the clinics. I'm looking at a prosthetic aortic valve, okay? Transthoracic, my best view of any leak in this prosthetic valve is in the anterior position of this prosthesis. Posteriorly, it gets attenuated. I come transesophageal, my best view of any leaks, actually the structure of the leak as opposed to the jet that maybe I can interrogate later, is posterior, right, and less anterior. So this is why you see and you read in the guideline, and hopefully also you understand, that I need actually these two modalities complement each other because of the limitations of ultrasound. This limitation is not present on a CT. It has other issues, right? This limitation is not, meaning attenuation, is not necessarily present in MRI. They have other issues. We have our own issues. But you need to know what each one of the modality has issues-wise, and that's why you're going to need that, okay? Now, we have other issues too. We have artifact. We have reverberations. We can have an artifact here particularly, and this is the transducer. Back and forth between the transducer, and we may have some little artifact there. Is this thrombus, or is this what is it? Okay, and use harmonic nowadays to decrease that artifact, or you could use contrast to improve the situation. I think that's how we get by. Another way to get away from artifact is to use another window, right? Use another transducer because some of these reflections are different. Or you use a low parasternal window looking at the apex. So you have to be innovative if you're seeing something and understanding, what the limitations of ultrasound, so you can, bypass some of these issues that you may see. These are, for those of you who have been in ultrasound almost like me, we've seen all this, okay? Meaning we were not digital at first, we became digital. Very high frame rate, we didn't have that. improved image quality, multi-frequency transducer, harmonic imaging, and we'll talk about that, tissue Doppler, digital storage, real-time 3D. And this is interesting because, you know, it has happened from the early days of ultrasound. And it's not that old, really. So we've seen all this, and I think I'm glad you're at this stage of the game so you can take, you know, the technology further. You hear about harmonic imaging, and I think it's an everyday practice on every, I mean, if you tell me in ultrasound, what is the thing that has been adopted within probably 2 years in ultrasound, unless you're thinking about, you know, how much dollar you want to save. This is one technology. Where, and why? Because it has improved imaging in general, took away artifact, and obviously we can use it for contrast. And so what is it? Well, when you send a certain frequency, let's say 3.5 or whatever, it's called the fundamental frequency. But when it travels and it hits various structures, that frequency emits with speckles, not only its fundamental, it's reflected and refracted, not only its in fundamental status, but its multiples or fractions of that initial frequency. So that F may emit a 2F, 3F, right, the higher frequencies, or even half subharmonic, okay? Always I do this, and pardon my voices and intonations, but if you're a music player, and most echocardiographers are music players, and if you're not, you should pick it up, as if you're a guitar or a piano player, and if you hit the string, these are string instruments, you hit the string a little harder, right? It has, besides what it emits as frequency, ping, right? It emits multiple of that. These are multiples, and it could be sub, because the sub can be even higher. So there is a spectrum of that. Now, why are we talking about this? We're talking about this because the early research was for contrast, okay? And we knew that contrast, these tiny little microbubbles that, you know, resonate whenever you hit them with ultrasound, hit them with fundamental, they emit harmonics. Okay, and we said, well, for you to best see them, therefore you have to image at harmonic, right? So if I'm sending at 2 megahertz, I would listen at 4 instead of 2 megahertz and get this strong signal from this. The interesting thing is that this is not what you plan, but what you get is that we never thought, at least the inventors never thought, that the heart would also emit harmonics, okay? So it's not only contrast, it's also the heart emit harmonics. So nowadays, most of the sonographers use harmonic to image even regular stuff. And what do you use? Well, if I'm sending at, whenever you read, let's say, 4 megahertz H, okay? It means I'm listening at 4 megahertz, but my emission is at 2. If I'm listening at 3, my emission is 1.5. And we have some sonographers who like to use this lower end, and we should not. And why? Because if you remember my first 2 slides, okay, the lower the frequency, the lower the resolution. Yes, you may see a little better, but the image will be very pixely and the resolution will be low. So if I'm imaging at 3, I'm sending at 1.5 megahertz, which is a very low frequency. I would feel comfortable if I'm imaging at least at 5 harmonic, and therefore I'm sending at 2.5, meaning that my resolution is decent. What is the problem with harmonic imaging? The good thing is that it takes away clutter. Okay, so this is the same heart, fundamental imaging on top. I can't see the apex well. The one with harmonic imaging on the bottom, I can see the image very nicely, the apex well. The clutter is gone pretty much. The problem with it, since you're using lower emitting fundamental frequency, valves would look thicker. Okay, and I know fellows, all right, love to give pathology to patients. Right? So Wherever there's calcium, I'm going to slap a calcium on it. Wherever there's thickening, I'm going to slap some thickening. All right? So decrease the thickening portion, okay? Just be gentle, at least for, I'm not saying, omit things, but don't feel good just labeling pathology. So keep that in mind, because the structures may look thicker. And for the sonographer, who's an astute sonographer, would go back to fundamental at a high frequency if there is something funny, all right? If there's just something maybe too thick for you to be able to do that. And that's why I think it's important for you to know. Obviously, the major application is contrast, okay? So without contrast, with contrast, now with harmonic. Now, I just wanted to show you here basically the difference, okay? This is the same patient. I show that all the time. The same patient within just a second apart, switching from fundamental imaging to harmonic imaging, okay? It's the same patient, same constant, same everything. Just tells you that the emission of contrast during harmonic imaging, it sends quite a bit of intensity of ultrasound, harmonic-wise compared to tissue, that you could differentiate nicely and you could enhance what you get by contrast if you use harmonic imaging. So I think that's pretty much standard nowadays, okay? We're done with 2D and M mode. Let's talk about Doppler, okay? Now, Doppler, interesting. Christian Doppler was lived and died before we were even not conceived, even preconception. Okay, talking about 1800s. That's where he lived, in Salzburg, Austria, and this is what's left from his birthplace, etc. And you don't want to look at down there. It's like lingerie and whatever perfumery there, but basically, and the beauty actually, if you go and visit, just almost around the corner was where Mozart was. So I mean, just imagine, all right, of how do you get to a Doppler equation, in those days, right? Looking at the stars, changing in color of the stars depending on how the stars were moving in relation to each other, and to come up with amazing equations that we use nowadays have been validated. So what does the Doppler thing say? Well, the Doppler equation says if there is an emission of sound, okay, of certain frequency, it doesn't have to be sound, it could be light, it could be anything else. And there is a motion of one object in relation to each other, this frequency will change. So they may change positively, may change negatively, may not change at all, depending on the position. So that's the Doppler principle in general, right? So the frequency will be shifted. So since we're using frequency and sound, and if I'm sending a 3.5 megahertz and the red cells are moving, or the muscle is moving, that frequency may not stay at 3.5 megahertz. Maybe 3.5 plus 300, 3.5 million versus 300, or minus 300, or minus 3,000 or 2,000. And the interesting thing is most of these shifts is in the audible range. And that's why you hear it. That's why you hear it. And in the past, we used to have, stereo things. So, the positive wave is on the right, and then the negative wave is on the left. And, we went through some interesting learning curves. So, that's what the Doppler, thing is. So, the other thing, so let's take an example, all right? So, this Doppler equation in it is interesting thing, this is the frequency shift we just talked about. It's related to the velocity of the relative velocity of these objects, to the emitting frequency, whatever that frequency is, and to an angulation, cosine theta. As opposed to imaging, where you want to be perpendicular and see the best reflected sound. For cosine theta to be 1 as opposed to 0, you got to be parallel. Either 0 degree or 180 degree. Okay? If you're at 90, you won't have a Doppler shift. So it will be 0. The whole thing will be 0. An example, all right? I always say that. If you're on Fannin Street and there's a siren or train is coming, if you close your eyes and you're on that street, you can tell actually that this moving object is coming towards you, and you could tell it's going away from you. Because if it's coming towards you, frequency shift will be higher. It came and left. Okay? Your best change in frequency if you're actually on that line. If I'm sitting here and I'm far away from this line that is going, I won't hear its frequency shift. I'll hear the same frequency. Nothing changing. Why? Because I'm perpendicular to the trajectory and it's too far. Right? Same thing here. Same thing's going to happen. In the past, our y-axis was frequency shift. That's how I started aortic stenosis with multi-frequency shift, that you had to solve the equation to get to the velocity and everything else. Now, your y-axis is velocity, keeping in mind that it is solving the equation for a theta of 0 or 180. So cosine theta is 1, all right? And if you're angulated, you're going to have to figure out, either you can measure it, or most of the time we don't measure it, we try to align ourselves with the velocities, right? So that's what we try to do. And where would that be important? Well, if you're 20 degrees off or more, cosine theta becomes very important, right? So you want to be as parallel to it so you have much lesser of an issue. Got it? I think that's very important, really. Now, you have, under Doppler, you have pulse, spectral, color, continuous. I think we need to go through that. Pulse Doppler. From the name, it is pulsating. And what does it mean? It means I'm sending a packet of this packet of ultrasound. It goes down, it travels, right? And ultimately it's going to come back. Okay? So the beauty of pulse Doppler is I can decide where I want to listen to. Here, I want to know in the LV outflow tract what these velocities are, what this frequency shift is. Okay? So what I do, I send this pulse, keep my ear, my transducer quiet. I won't listen till this thing travels to the sample volume and goes back. So I know how much time it would take. Then I open and listen, and I ask the question, what is the frequency shift? I sent 3.5 megahertz. What is it now? It's 3.5 plus 300. And it's going positive, so it's going, or negative here in this situation, it's going negative away from me, right? So I can solve it. And what does the physicists use? They use fast Fourier transform to be able to solve. I mean, these are complex equations for you to be able to see that. And then ultimately this is put in a spectral display for you to see. So basically, in this pulse sample volume, I sent this packet. I listened after a while at that depth, and I've listened to it, and I think the velocity, all right, or the frequency shift occurred more negative, right? This is 0, more negative. And here, all of them are together, so most of these red cells are aligned together. Once they start slowing down, some of them are going a little faster than others, and that's why you see spectral broadening. That's what it's called, right? And then deceleration. Okay? So that's pulse Doppler. Because you can range gate, that's the beauty of it. Okay? One problem with it is, since I'm pulsating, it's almost like a stroboscopic light. Okay? There's a certain frequency that I can be able to do that, so I can resolve what the actual velocity is. Okay? You need to have this pulse repetition frequency to be at least 2 times the Doppler shift. An example for you. If you still go to a disco or something like this, right? I don't know some of you. I haven't been to any of those lately. But if you go there, right, there's a strobe light. And if somebody is moving, there is a certain frequency for the strobe light for you to be able to tell the movement of that person. Otherwise, you're going to have a very funny movement of that individual that may not be real. Same thing about if you look at even nowadays, because the camera has a certain frequency, you see the wheels, you know, the camera of a car moving, and then you see them rotating back. That used to be much more in the older days because the frame rate was not as fast. And nowadays, I think we have lesser of an issue because it's almost real time, right? So these are some examples of this situation. So you need a certain pulse repetition frequency. And this is then, if I don't have that pulse repetition frequency, I'm going to have aliasing. The word aliasing meaning I'm not able to tell what the actual frequency shift or what the velocity direction is. So you could see above the line and, you know, under the line. And we have a trick, so you can change your baseline since you know where the direction is, but beyond 2 times of that, it's going to wrap around, right? And that's what happens with what? With mitral regurgitation or any high velocity. You know, a pulse Doppler is not going to be able to do that, so you're going to see, you know, basically, you know, a mishmash of frequencies there. You're not going to be able to solve them. And that's where you're going to need, you know, continuous wave Doppler to be able to solve that equation. Okay? So how about color Doppler? Color Doppler is not much different in a way. Color Doppler is an estimate of pulse Doppler technology. It is really an estimate of that. And you know, it is made of little tiny, if you will, sample volumes. You're not going to be able to have the time to solve well this, so it's an estimator. You know, don't use a fast Fourier transform analysis to come up with what the velocity is, so we'll give you an estimate. And the estimate is, what's the mean velocity is on the average in that area? Which direction? Is it going forward or is it going backward? And it took a few years for people to acquiesce and, hey, you know, going away from us is going to be blue shade and coming towards us is going to be in the red shade. At least we don't have controversy regarding that. Okay, so I think the utilization of that certainly in abnormal jets, etc., and we'll talk about those sometime down the line. Aliasing, not aliasing, a change in direction in color Doppler is blackness. Okay, how do you differentiate aliasing, going from one color to another, to change in direction? Change in direction is basically you'll have a period where you are perpendicular to the flow and the frequency shift is 0. So it's going to be dark, nothing. Okay, so here, like the aorta, ascending aorta, coming towards the transducer, perpendicular, going away, you're going to have all the shades of it, and that's how you're going to differentiate it. This is very important. How do you look at basically color Doppler? I mean, nothing in ultrasound, I don't know about the others, but nothing in ultrasound is fully automated that you don't have to deal with. Everything is dependent on how you acquire and gains and other things, all right? And so you have to optimize the image one way or another for you. Gains, color map, frame rate, Nyquist limit, all these are important. Same jets, low gain on the left side, high gain on the right side. How are you going to interpret that? So we know by convention is that you use high gain and come down a little bit. So you have a little tiny speckle in the background, so at least you optimize, quote unquote, the gain. Okay? Rather crude, but it's important because at times people overgain it or undergain it. And I think, you know, Carlos had a nice case, I guess, in the valve regurgitation document online where undergaining underestimated regurgitation. So I think these are very important for you to know. So that's number one. 2, Nyquist limit. Where you decide, Nyquist limit is where you decide your scale. If you want to emphasize the lower Nyquist limit and the lower velocity, you're going to fill in all this with blood velocity, right? So here, this is the Nyquist limit, and the way you read it is this is 0 and this is 21. Look at that, okay? And this is the appropriate one. The appropriate one should be at, here you go, should be between 50 and 60, something like this, right? So this is the same case. Regurgitation has improved so much, right? It has improved so much. And to tell you the truth, if you think this is theoretical, you'll be surprised. So when you call to the operating room, when you call in a different situation and said, oh, the MR was mild and now look, it is severe. And actually, these are some of these cases. Indeed, somebody had played with a scale, played with an aqueous limit, and here you have that. So you need to know your basics for you to interpret things, right, the way they are. I think that's important. Frame rate is crucial because, as we talked about, by 2D imaging, you can get to the hundreds of frame rate. Color is always, and 3D is always very important. Your frame rate is really your major limiting step. So further depth is going to ask you to basically wait longer and longer for you to analyze all these data. It's going to slow down. Width of the sector, right? It's going to take much more time for it, to process all this. So, you have to remember those. Line density, we don't change much in it, meaning how many times you fire along the same line before you move to the second one, right? We usually fire about a couple of times before you move. It's not only a single shot, okay? I'm going to skip high PRF. If you're interested, I think we can take a look at that. Maybe you should read about it. This is continuous wave Doppler. So basically, from the same transducer, I'm sending continuously. It's no longer bursts, packets, sending continuously and receiving continuously, so that I'm not limited anymore with stroboscopic light. It is ambient continuous light. So I can see. Now I can see meaning I can resolve velocity. But as opposed to this, I'm resolving these velocities along a certain scan line. And anything goes. It's like superimposing your image to that in the back, to that in the back, anything goes. And since I'm interested in velocities and timing, I look into it and see what is the situation. I cannot differentiate a subaortic stenosis from an aortic stenosis or a supraaortic stenosis, since all of them are lined up in the same situation. So you have to couple it with something else for you to know, and at least physiologically know, where the situation is. And this is an example of an aortic stenosis there. Okay? Tissue Doppler. Same principle, nothing different. However, we suppressed this long time, for many, many years. Actually, we rediscovered it 15 years ago or so. Okay? I would say 20 years ago. Time is flying quickly. And the reason for it, we suppressed it because it was more noise than anything else. Just imagine, you're looking at the ventricle and you're looking at flow and everything else. And the interesting thing, you can suppress it or turn it on because the characteristics are very different. Meaning, intensity, this pulse Doppler intensity coming from muscle is very high intensity, low velocity. All right? Heart muscle moves very slow. But coming from a muscle as opposed to a red cell, right, the intensity of the signal is very high. So I have this high intensity, low velocity versus low intensity, high velocity. So I can display either. That's how we displayed blood for many, many years. And now we've discovered that there's a lot of information in the muscle, right? So that's all the tissue Doppler applications that you see. You saw color Doppler. Speckle tracking is a different ballgame, is another application. I attended the first presentation of this, and I think you're just like, wow, I was waiting for this to happen because your eye is following the speckles as opposed to the computer following the speckles, and now you could do so many things. It's not angle dependent, right? And from it comes strain and strain rate. What is strain? Is deformation. Deformation. Now, don't get hung up only on global longitudinal strain. This is one part of the vector. All what deformation is, if I have a piece of muscle that either stretched or compressed, but it is expressed and compressed in multiple angulation, it's not only in the longitudinal vector. So you can't forget about that. So strain is a deformation, right? If I have shrinking of it, its percentage is almost like thickening, if you will, in one of the vectors. And strain rate is the rate of this. So this is a slow strain rate. It's the same deformation that has happened, but on the right side is much faster. Unfortunately, strain rate hasn't gotten caught up as well because of noise in the system. But as things get perfected, I think this is where myocardial properties, I think, would be very important, because remember, you can end the same place, but the rapidity with which as you end in that place may be actually the true thing. So we talked about longitudinal strain. There is circumferential and radial coming in, right? So you take an example of a patient with hypertrophy. Longitudinal strain goes down, but radial strain goes up. That's why ejection fraction kind of stays the same or is hyperdynamic. And nowadays, all these can be computed electronically without you, but they are also dependent on noise. You have to always, with your eyes and your expert eyes, always take a look at that and make sure that the data is correct in a way and accurate to be able to get. Okay, let's see here. Looks like got stuck. All right. And digital, the beauty, you haven't lived in before digital, but the beauty of digital for us is to be able to do so many things, go back and forth, and particularly in this is to take a look at the heart at the same time in different views. Remember, it's the same heart. So for you to interpret function, many other things, you have to kind of put things together. It is not served on a plate for you. And I think a differentiating of an expert from the others is the experience that you get by putting all these data together and not be overwhelmed. It comes with time. It really, it is not simple, but it will come with time. I think digital technology certainly has improved this so much. And in our lifetime, certainly 3D is here, so I think 3D is really very important for us, going through. One thing is it will slow your frame rate down. There's no question about it, right? Because you're imaging in multiple directions at the same time. You have a C-plane that you can image from. In the past, this is how we started. You had to basically do fusion of sequential beats, so they're not the same, so you may have some stitching artifact, if you will. But nowadays, I think most of the time you could do it really with one beat, and I think that is, very, very, certainly very helpful. There's high frame rate, volume frame rate nowadays that you could do, and global strain, 3D strain. The images with transesophageals are amazing. You tell me, where are we in transthoracic? Nowadays for transthoracic, I think the sonographers, I would ask you to perfect at least getting a good, volumetric assessment, ejection fraction assessment. Where it's helpful, tremendous to us, is multiple regional abnormalities of this heart that you have to integrate, et cetera, and maybe we should concentrate on the right ventricle a little more. So I think this would be important for us, going forward. Okay, so a few other things here before we leave. One is, this is the depiction basically of the field. You could time yourself on where you joined. I joined here, somewhere in this field, right there. Where color Doppler, we're just starting. The color Doppler machine was like a refrigerator. It's huge, and actually our E4M 2D machine at Bentab Hospital was quite large, was a refrigerator too. But it is amazing that with the same technology, things have improved so much. And with the same principle, the only principle that really came different is here with Doppler. All the other imaging is the same principle, is localizing and looking at the intensity and how real time can you see it, what's the resolution that you could see it at, and the other one is flow and flow calculations. And I think among all the technologies of imaging, certainly Doppler is really number one for looking at various flow here. Globally, I think MRI is certainly, a great, but CT is problematic because of its time resolution that it brings to. And I want to end it just with, how many years ago now? 58, right? Take a look at this. Let's see if I can, how I'm going to be able to do this here. There you go. This is our sonographer of 1960. And that's Dr. Edler himself on the right side. Dr. Edler is so relaxed, he can put even his left hand in the pocket. And look at the excitement. Isn't that amazing? That's all what you could see then. And it was amazing, because actually that was the birth of this field. So thank you very much for your attention. Any questions before we leave? All good? All right, see you next week.